A standard hearing test operates on a simple behavioral feedback loop. The clinician plays a tone, and the patient raises a hand. It requires a conscious, cooperative subject to confirm that sound has been registered. But this methodology hits a strict clinical limit when that feedback loop is broken. If the patient is a sleeping infant, comatose, or otherwise unable to respond, traditional behavioral audiometry produces no actionable data. To assess auditory function without relying on conscious feedback, clinicians utilize the auditory brainstem response, or ABR. Surface electrodes are placed on the patient's scalp following the International 1020 mapping system. These sensors detect the synchronous electrical activity generated by the nervous system in response to an acoustic stimulus. What they record is a real-time, microsecond accurate map of the auditory pathway, tracing the exact route the signal takes from the distal 8th cranial nerve up through the mesencephalon. The ABR removes human subjectivity entirely. It turns hearing evaluation from a behavioral assumption into a purely objective topographical map of the central nervous system. This split-screen graph displays a standard, healthy ABR readout. As the electrical signal is tracked, it produces up to 7 positive wave peaks, labeled with Roman numerals I through VI. If we overlay the readout of a patient with a cerebellopontine angle tumor, the contrast is stark. The waveform is severely delayed, and the peaks fail to align with the healthy baseline. The x-axis of this graph measures absolute latency in sub-millisecond intervals. In this diagnostic space, a delay of just 0.4 milliseconds signifies pathology. Each specific peak on this graph is generated by a distinct anatomical relay station along the brainstem. As the electrical impulse hits a new cluster of neurons, it registers as a wave. To understand exactly what creates these peaks, we have to trace the signal backward, starting from the mechanical structures of the ear and moving deep into the brainstem. By decoding the exact microsecond delays in this waveform, clinicians can pinpoint the specific millimeter of nervous tissue where an auditory signal is failing or being compressed. The electrical signals of the ABR begin with physical mechanics. Sound waves strike the tympanic membrane and drive through the ossicular chain. This reduces the surface area, amplifying the sound pressure by a factor of 20 to achieve impedance matching, forcing the acoustic wave into the fluid environment of the inner ear. Inside the cochlea, fluid movement displaces the basilar membrane. It has a strict physical gradient. High-frequency sounds deflect the stiff basal end, while low-frequency sounds travel further to deflect the flexible apical end. Mapping specific frequencies to physical locations is called tonotopy. As the membrane moves, it pulls microscopic tip links on inner hair cells. This mechanical tension opens ion channels, causing an influx of potassium that depolarizes the cell and fires an electrical signal. Simultaneously, outer hair cells physically contract and expand, actively amplifying vibrations. The cochlea is a highly active mechanical transducer. It converts raw fluid dynamics into the exact electrical starting line required to generate auditory brainstem responses. Looking back at the ABR graph, we map that electrical starting line. Exactly 1.5 milliseconds after the stimulus, the first peak emerges. This is wave 1, generated at the distal 8th cranial nerve, the vestibulocochlear nerve, as the signal leaves the cochlea. An absence or delay at this exact mark indicates immediate peripheral failure, often pointing to cochlear ischemia or infarction before the signal reaches the brain. A millisecond later, at the 2.5 millisecond mark, the signal produces wave 2.
It has a dual anatomical origin, marking the impulse traveling through the proximal auditory nerve and entering the cochlear nucleus, the first relay point in the posterolateral brainstem. A normal reading for waves I and 2 proves the electrical signal successfully escaped the inner ear, reaching the boundary of the central nervous system. As the timeline hits 3.5 milliseconds, wave 3 appears. Neural fibers leave the cochlear nucleus and cross the brainstem's midline into the contralateral superior olivary complex. This crossing is decussation. The complex is the first station receiving bilateral input from both ears simultaneously. Because it acts as a bilateral junction, any anomalies or delays in wave 3 are highly indicative of a lesion on the ipsilateral side, the same side as the stimulated ear. At 4.5 milliseconds, wave 4 registers as ascending auditory fibers travel up the lateral lemniscus tract. Finally, at 5.5 milliseconds, the signal hits the inferior colliculus, generating wave V. Out of all the peaks, wave V produces the largest amplitude. It is the most prominent, reliable, and clinically analyzed marker for determining a patient's overall hearing thresholds. Wave V is the ultimate diagnostic beacon. If it arrives intact and on time, it verifies the structural integrity of the entire lower auditory pathway. When a patient experiences hearing loss, the ABR map allows clinicians to differentiate between a physical, conductive blockage and a structural, sensory neural pathology, such as a vestibular schwannoma. This side-by-side comparison shows how a tumor disrupts the signal. As a vestibular schwannoma physically enlarges, it compresses the auditory nerve. This creates a severe prolongation of the interval between waves 1 and 3, slowing the electrical conduction. To confirm the diagnosis, clinicians use stimulus intensity scaling, incrementally increasing the decibel level of the acoustic clicks driving into the ear. If the patient has a simple conductive hearing loss, like fluid in the middle ear, pumping up the volume forces the acoustic wave through the mechanical blockage. The ABR wave latencies will suddenly snap back to normal timing. But if the delay is caused by a neural conduction pathology, like the physical mass of a tumor compressing the nerve fibers, increasing the decibels completely fails to normalize the latencies. The delay persists regardless of volume. By simply scaling up the decibel volume and observing the resulting timeline behavior of these waves, a clinician can definitively separate a mechanical fluid blockage from a structural neural tumor. A final ABR result is never a single reading. It is the highly filtered, averaged response to several thousand repetitions of broadband acoustic click stimuli, designed to isolate the true neural signal from background noise. However, this methodology has a known diagnostic limitation. The ABR misses roughly 30% of small acoustic tumors, measuring under 1.5 centimeters. This blind spot exists because of tonotopy. Small microtumors may not compress enough of the high-frequency basal nerve fibers to meaningfully delay the critical latency of wave 5. When an ABR screen does detect a failure, it immediately triggers a multidisciplinary treatment pathway. This ranges from audiologists initiating early cochlear implantation for infants to neurosurgeons planning precise brainstem resections to preserve existing auditory function. Despite its limitations with microlesions, the auditory brainstem response remains the global gold standard in neuroodontology. It grants clinicians the tool to illuminate invisible neural highways, ensuring no vulnerable patient is abandoned to the silence of an undiagnosed deficit.